All right. Good afternoon, everyone. I'm Bethany Hamilton, co-director of the National Center for Medical Legal Partnership based at the George Washington University. You're joining us on June 6th, 2023 for a really important webinar or virtual town hall that's focused on Medicaid. We know there is a lot to discuss with regard to Medicaid, community health centers, the patient populations they serve, as well as medical legal partnerships and those who are served by legal services organizations around the country. But we've decided to focus on some of the most important and significant and changing topics in Medicaid today: redeterminations, work requirements, and coverage for undocumented persons. I'm joined by our NCMLP colleague and consultant, attorney Katie Hathaway, who will be taking over in just a moment to provide introductions, level set us on the topic for today, and just go through a little bit of housekeeping so that you know how we are funded and supported today and how you can engage in this town hall discussion. Let's go to the next slide. So who's funding us, who's supporting this work, is the Health Resources and Services Administration. You may hear some of our panelists today provide remarks that are particularly focused on the health center patient population because of that health center model for delivery. But all of our panelists today will really be focusing on a broad array of topics related to, or excuse me, the way Medicaid as a policy it really informs our work, not just through the health center model, but through various models. So thank you to HRSA for continuing to support our work. Also, we'll look forward to, as NCMLP, continuing to bring you training and technical assistance content in the future and tap years. So let's go to the next slide. This is Zoom webinar. To engage, we are encouraging you to send questions to us through the Q&A, but you will actually notice that the chat function is on, and you are welcome to, in this town hall style presentation or training event, utilize the chat to share commentary. We have received, for those who registered well in advance, questions and comments that were submitted in advance, and so we've actually reviewed those. We do believe that many of those questions will be addressed during the panelist remarks, but go ahead and feel free to engage in the chat. Our panelists will likely be in there as well. We'll be sharing resources, and certainly reach out using the chat function to let us know if you've run into any technical difficulties. This webinar is being recorded, and both the slides as well as the recording archive itself will be found on medicallegalpartnership.org resources. We'll be sure to send a follow-up email to all of the audience. Also, we are transcribing this event. So to activate the captions, you will select in the Zoom functions live transcript and show captions or show subtitle. Katie, let's go to the next slide. All right, this is actually the final webinar or training event in the series that we kicked off earlier this year. One of our panelists actually joined us to kick off the entire Health Center MLP Toolkit series, really level setting us in terms of data that have been collected regarding the social needs of health center patients. As Brad Carl from KFF helped us present alongside APCHO. And it looked at data, especially as we were coming out of the pandemic, and it included a highlight about legal needs that were being reported as a result of or during the pandemic. Now we are ending on a more policy-focused topic, that's Medicaid, and then the subtopics that I'd mentioned that Katie's going to explain a little bit more about. But I really want to acknowledge that medical legal partnerships have been working on Medicaid policy and beneficiary access issues for many years. This is the bread and butter of civil legal aid services, and being able to deliver these services through setting up a partnership in a healthcare setting makes it even easier to be able to connect those individuals to coverage, to access, and overcome those really complex policy issues that require legal expertise. So it's about meeting people where they are to be able to address the legal needs. And what we're going to hopefully be able to talk about today is just provide you with updated information on how many of these policies are changing and how you can engage to make beneficiary access easier and better. With that, I'm going to pass it along to Katie to introduce you to today's speakers and help us better understand how we're going to engage in the town hall discussion. Katie, all yours. Let me know if you need any assistance with the slides. And thank you.
Yeah, I think I'm good. Thank you, Bethany. So today's, sorry, I'm not sure why it stopped. Do you see the slides?
We can see the webinar series slide.
Okay.
I can flip slides for you though, if you give me just a moment.
Yeah, it stopped flipping slides for me, and I'm not sure why. Well, thank you for that. Okay. So as Bethany mentioned, this town hall today is about Medicaid policy and really the areas in which currently there is a lot of policy development, a lot of change. And I say currently, going back a couple of years and for the future. As we mentioned, we have 3 different topics in this section. I will say we have just a bit of a numbers game. We have 2 moderators today, 6 panelists, and 3 topics. So we've got a lot to cover. So let's jump in. So we have 3 different learning objectives today. The first one here on the screen, understanding the most common barriers, not the only barriers, but the most common barriers to healthcare experienced by low-income and disadvantaged communities. We're going to learn a bit about current policy efforts, like I said, current developments affecting this patient and client access to Medicaid, and gain a better understanding of the role that that health centers, medical legal partnership providers, legal services, social services providers play in supporting access to Medicaid. Slide. So you've already met Bethany on the first slide. Bethany and myself are your 2 moderators for today, and we're going to tag team this a bit. I'll be talking us through with the panelists for some commentary and discussion, and Bethany will be monitoring with Annalise, our colleague, monitoring the question and answer box and the chat box. As she said, encourage you to use those. So definitely keep an eye on those if there are questions that you have, or if you just like to keep track of any commentary that your fellow audience members may be providing in there. I am a consultant with the National Center, and Bethany is the co-director. As I said, we have 6 panelists today. We have an outstanding group, so much so that it's hard to fit them all on one slide. But also, I want you to hear directly from them instead of from me. So I welcome briefly Stuti, Carrie, Brad, Leighton, Jay, and Norma as our panelists today. They will next give a bit of a self-introduction and some comments about their work in this area. But really, we are thrilled to have such a wonderful group of national experts, policy experts, researchers, medical legal partnership providers, advocates, people who have really engaged in this work in a number of different forums and different ways. So I'm excited to hear from them and to learn from them myself, and I hope you are too. So a general welcome. As we said, both based on the opening comments and the name of this town hall, we have limited this to primarily 3 topics, and we recognize that these are not the only issues of interest or even the only important policy issues around Medicaid these days, but the ones that really are percolating to the top of most discussions and a lot of both legislative and legal work, and probably are most impacting your patients and your clients directly on their mind, is the Medicaid redetermination process, the unwinding of the public health emergency rules recently, and what does that mean in practice after more than 3 years of not having this process happen. And a lot of data around that, and I think we will hear a lot about what we are starting to see and what we are starting to learn about how that process is going, and perhaps what opportunities there are for engaging to either redirect or encourage or do whatever we need to do to influence that process. The second topic are Medicaid work requirements, broadly defined work requirements, what has become a bit of a re-emergence to the extent that they ever went away in some places, but a re-emergence in some state Medicaid waivers, some federal proposals and legislation, sort of a very fast and rapidly evolving area of policy development. And finally, the third topic is also a very crucial one for a growing number of individuals, and that is Medicaid coverage for persons who were undocumented, whether that be youth up to a certain age or adults in certain age categories, whether it be, look-alike Medicaid programs, and what that landscape looks like in a couple of places, and to the extent that we can describe it nationally, we will do so. So that's where we're going to focus today. The way we're going to do this is we're going to have each of the panelists introduce themselves and provide a little bit of commentary. We will then move to a discussion of those three topics that I just described, and then we will address any questions that remain unanswered or that you have posed to us today. But I'm excited. I'm going to turn this over next to Stuti and Carrie, who will introduce themselves and talk about their work in Illinois.
Hi, everybody. I'm Carrie Chapman. I use she, her pronouns, and I am the Senior Director of Litigation and Advocacy at the Legal Counsel for Health Justice. I'm going to be really brief in my introductory remarks and let Stuti just give you a little bit of information about her work as well. And then we will be later on in the program diving into the Medicaid redetermination issue. So Legal Counsel for Health Justice is a small unrestricted legal aid program. That means we don't take LSC funding and don't live with the LSC constraints. We focus on trying to increase health equity and health justice for communities in Chicago and throughout Illinois. And we do direct service. We do administrative advocacy with state agencies, school districts, et cetera. We do legislative advocacy, we lobby. And then we file class action lawsuits. So we kind of do the range of services for communities who need to see an increase in their access to healthcare, health coverage, and health justice. Basically all of our clients come to us through medical legal partnerships. So that is we have about 17 partnerships with either medical centers and some with social service agencies, particularly serving individuals who are homeless. But our entire model is to integrate legal services into healthcare and social service settings. We have been working a lot on Medicaid policy. So, as a result of our mission, that's a main focus of what we do. We work on policy at the state level and at the federal level. In addition, we litigate against the state of Illinois sometimes when necessary on Medicaid issues to make changes in Illinois Medicaid law or policy. And with that brief introduction, I'm going to turn it over to Stuti and let her tell you guys a little bit about her work.
Good afternoon, everyone. My name is Stuti. I also work with Legal Counsel for Health Justice. I work as a National Health Corps member, which is part of the larger AmeriCorps organization, if any of you guys are familiar with that. But my role is to increase legal counsel's capacity to provide legal services by increasing outreach and providing educational materials for both clients and internally as well as externally. I collect data and analyze trends to see the impact of our services and if we need to make any changes to the way that we are providing our services. And I also do some screening and intake for clients. But the large role that I play is developing communication strategies for legal counsel. And I actually posted a blog on the MLP Illinois page about the unwinding of the Medicaid continuous enrollment provision, which is how I got into contact with Katie and how we're able to present today. But I haven't been in this field for super long, which is why Carrie here is here to answer specific questions on the redetermination process, because she has a ton of really great experience with that. But I did want to emphasize the role that non-case handling staff plays in legal aid organizations and just the importance of having good communication with clients and stakeholders in general, because effective health communication is just as important to healthcare as clinical or legal expertise. And outreach is going to be a very critical part during this unwinding process to ensure that those who are eligible for Medicaid are able to maintain their coverage, and those who are no longer eligible are transitioned into a marketplace plan or some other type of insurance. And changes to the redetermination process are ongoing, so it's important to make sure that these resources are updated as new information arises and best practices need to be changed. And I think that this is where having non-case handling staff is really important because they're able to create these communication materials and distribute them, keep them up to date and make them eye-catching so people actually read them, and make sure that they just are going to the intended audience, and making sure that all that information is widespread and accessible. And having these non-case handling staff do this is really important because it increases the capacity of attorneys and legal advocates to more focus their time on their existing clients or new clients, and just allow for a deeper connections to be formed with their clients, which then leads to better understanding of their clients' needs and ultimately leads to better health outcomes. So I will also be attaching my blog post to this chat that has some important information that's regarding the redetermination process in Illinois. And I also have some helpful communication materials. So be sure to check it out when you have the time, and I'll also be linking some other information as we move along. But thank you for having both of us here today.
Thank you so much, Judy and Carrie. I'm really thrilled that you have all that education work. I really enjoyed the blog post, which you're right, that's how we got connected, caught our attention. I'm going to turn it over next to Brad.
Thanks, Katie, and hi, everyone. It's nice to be here. My name's Brad Corallo. I'm a senior policy analyst at KFF, formerly Kaiser Foundation. We've since switched to just the initials. And a lot of my work at KFF focuses on researching Medicaid eligibility and enrollment issues, as well as issues related to the Community Health Center program. So I'm very happy to be here today. And a lot of our work really, especially for the Medicaid and the uninsured program here at KFF, is really about taking these what's happening now, if they're complex policies, summarizing them and disseminating that information out in a nonpartisan way. I did have a few remarks I wanted to make about work requirements for our discussion later, but before I kind of get into a kind of a key level takeaway from that, I wanted to plug two resources that I think would be of interest to people on this call. First, KFF recently launched an unwinding tracker. And essentially what we're doing there is we are taking all of the state reported data that is publicly available and putting it into one place. So that includes, state reported data on enrollment, disenrollment, renewal outcomes, all in one page. So you, for example, you could, look at the number of ex parte renewals in Pennsylvania. You could look at the number or the rate of procedural disenrollments in other states that are making that information available. So it's a great way to see kind of how the unwinding is unfolding across the states. We're updating it as data become available. And we are going to be adding a new summary where we kind of aggregate the data. So what can we say about disenrollments, renewal outcomes, how the unwinding is going generally across states with the data that we have and given the limitations of that data. And looks like I'm going to plug that into the chat just so you all can check it out. And we'll continue updating it throughout the months-long unwinding process. So hopefully that link is in the chat. The other resource I want to link is a link to is not so new. It's something that's been around for a while. It's KFF's Section 1115 waiver tracker and Medicaid. We did recently kind of revamp it to kind of highlight themes that the Biden administration has been prioritizing. So if it's been a while since you've checked out the waiver tracker, I recommend taking another look. And one reason I wanted to particularly raise it for this group is because we have archived a lot of really detailed information about waivers with work requirements. The caveat is it is an archived webpage. That data are and summaries and information about those waivers are as of May 2022. But it is, a great rich source of information if you want the context and the background for some of these waivers and what happened and some of the litigation surrounding the work requirement. So it is a really useful resource. So with that, just to kind of like briefly give like an overview of some of the work that KFF has and some of our key findings and messages from it is we've produced a number of research publications on this. And one of our big findings that KFF has done in our reporting is that we found that when it comes to work requirements, we know that the majority of enrollees are either working, caregiving, attending school, or not working due to illness or disability. And so work requirements where they make eligibility as a condition of having a job or performing work activities puts large numbers of Medicaid enrollees at risk of losing coverage solely due to reporting snafus, despite working or qualifying for an exemption. And this is all really so that states can track the work activities of a pretty small number of enrollees who are not working and do not qualify for exemptions. But there are other ways Medicaid can support work and employment without conditioning their eligibility on work. I would say, first of all, stable Medicaid coverage in and of itself supports work. And we know that because enrollees have reported that Medicaid helps them manage their chronic conditions and support work, their ability to work, especially in physically demanding jobs. Second, some states and health plans are providing work supports already, but they're voluntary and not conditioned on eligibility. So these might look like, employment screenings, job referrals, things like that. And generally, if the goal is to increase employment among enrollees, then targeted voluntary work supports have been shown to be successful. And these are a more generally targeted way to address the smaller number of Medicaid enrollees who aren't working, rather than using a more blunt work requirement that affects the larger population. So that's kind of like the elevator pitch, if you will.
Thanks, Brad. That's a long and hefty elevator ride. There's a lot of data and a lot of trends in there and a lot of history of tracking that work. Thank you for that commentary. I'll turn it next to Leighton. Leighton, you're on mute.
You have to hit unmute.
Good. Hi, I'm Leighton Koo. I think all I'm supposed to be doing is introducing myself. I'm a professor here at George Washington University. Actually, I sit in the office right next to Joel Teitelbaum, who is also with Medical Legal Partnership. I've been doing research and advocacy about Medicaid, community health centers, et cetera, for an awfully long time. Both here at GW as well as before this at the Center on Budget and Policy Priorities and at the Urban Institute. So I'm not going to go, I think I'm not supposed to talk about my bit about work requirements quite yet. I think that's coming later in the sequence as I understand it. So we'll get to that later. One thing I will comment is just earlier today, I was in a nationwide conference call with 30 of the sort of leading researchers about Medicaid on the unwinding topic. And, people were feeling pretty desperate and concerned about unwinding as it's beginning to occur. Some of the things that Brad has mentioned that show how the tracking is going indicate there's some serious problems going on in some states. We don't know the situation in all states, but this is an opportunity. Hopefully you guys out in the field can be monitoring these things more closely to the extent that you have the ability to intervene at state levels or with media, or ultimately to communicate with people at the national level like me or Brad or some of the others, or with CMS to try to step in. That's also very helpful. So ultimately, you guys are closer to what's going on than we are. And with that, I'll just stop saying anything about myself.
Thanks, Leighton. We're looking forward to all of that years of expertise, what you can share with us as we dive in a little bit. I'll turn this next to Jay.
Thanks, Katie and Bethany, for inviting me. I appreciate the opportunity to participate in this webinar. My name is Jay Sicklick. My day job is I'm the Deputy Director of the Center for Children's Advocacy, and when I put on my MLP cape, I've been the director of our Connecticut Pediatric MLP for almost 23 and a half years now. I've been around again since the long in the tooth days of MLP, and we've established a pretty vibrant, if not really successful MLP in Connecticut, which is really based around pediatrics and young adults. We're affiliated, our core sites are at Connecticut Children's Medical Center, which was our first partner, then joined by Yale New Haven, the Yale New Haven Health System and the Yale School of Medicine. And we're also affiliated now for the last 3 years with the Yale Child Study Center in what we believe is really the first exclusive behavioral health MLP in the country. We've been doing Medicaid work really since the inception of the MLP, both on an individual level and a systemic level. And really, we started handling individual cases when Connecticut belonged to the managed care organization Medicaid system. And we never had a dearth of cases. We pretty much got one in every day, given the kind of dysregulation and the ineptitude, if I can say that, of that particular system. But Connecticut abandoned managed care many, many years ago and went back to old school fee-for-service Medicaid. And so our policies shifted from really more individual work to systemic work. And that's where we got involved, I think, in some pretty significant partnerships to really look at systems initiatives and where some of the specific faults lay in the Medicaid system in Connecticut. And specifically, we focused for many years on behavioral health. Not that by any means we've solved that. Those of you who are in the Medicaid system know that that is a low-hanging fruit for any advocate to try to repair. But it is a long and arduous battle. But without getting into too many of the details, that was our first foray into really significant systemic reform. But about 2016 or so, we shifted our focus into expanding coverage by virtue of our work with pediatric partners. And that really consisted of our pediatric health advocates, physicians, pediatricians, clinicians, other folks who dealt in the space of pediatric and young adult health. And that's where we've really been focusing on, and that's where I'll spend my time in the second portion, at least when we get to the specifics. But what we tried to do is we tried to think a little bit more creatively in an area that was not very welcoming. And as I was going to save this line until the second part, but those of you who reside in certain parts of this country can go out and take a lunch break when we talk about expanding coverage to undocumented individuals in the state-funded Medicaid program. And I say that kind of tongue in cheek, but it really is the reality of where you sit will inform how your partnerships can really influence specific advances in expanding and increasing this coverage. And I'll get to that. But the take-home points I want to make here are that we recognize that in the behavioral health realm, we were able to work with our pediatric partners, but the strength of our legal advocacy was really carried that initiative. When we started working on this expansion, we recognized that just because we were lawyers and we had pediatric partners, that was not enough. We had to expand the pie in terms of collaborative partners. And that's why really connecting with really 4 pillars of partners, the medical advocates, as we've always been partnered with, ourselves and other advocates in the legal realm and other kind of, legal-based advocacy, grassroots advocates, which really became a new partner and a welcoming addition because we had done work with advocates and individuals in grassroots settings before, but in a different area in immigration advocacy. And then stakeholders who were funders, who wanted to make this happen, who really had a real insistence on driving this from the finance side. So those are the 4 players that we have kind of gathered together at the table. And this has really resulted in a really impressive, although frustratingly slow incremental increase in coverage, which I'll get to in part 2. So that's a little tease so that you can hang in there for the second part. But just as of today, we have some good news in terms of incremental increases in coverage. But some of the pitfalls and some of the real catalysts to these efforts, I think, were more fate sometimes than actual specific intent. And I'm sure most of you can recognize how the pandemic played into this and how it really informed, again, a lot of the work that we did there. So again, thanks for inviting me and letting me participate, and I look forward to the remainder of the session.
Thanks so much, Jay. Really great reminder of the connection between individuals and the health harming social needs and the legal issues and systemic reform and the need for that kind of advocacy. So looking forward to that. Norma. You need to unmute yourself.
I'm so sorry.
There you go. No worries.
Thank you so much for inviting me to participate in this program. I'm really happy to sit amongst so many experts in so many different areas. So I'm currently a senior supervising attorney with Legal Health. We're a medical legal partnership. And since 2001, we've been providing general legal services to patients of our partner hospitals who are facing severe illness. We partner with about 36 hospitals and community health organizations. Our work also involves training of medical professionals on the challenges their patients are facing that might be exacerbating their medical conditions and impeding healthcare. And our work is principally to increase or improve outcomes for the patients that we see at our partner sites. So it could be the New York City address, but the immigration is by far our largest practice area. I've been practicing with Legal Health for the past 16 years, first as an attorney with clinics of my own at Bellevue and Elmhurst hospitals. These are two of the hospitals that are part of Health and Hospitals, which is New York City's public health care system. They are one of our largest partners. The hospital staff primarily utilize my clinics for referrals of immigrants, patients who are seeking both immigration status as well as access to care. I later left direct legal clinic work to supervise the immigration practice of Legal Health and to help support our attorneys in their immigration work that's generated by their individual clinics at all of the various partners that we serve. I also provide guidance on changing immigration law, policy, procedures that affect the work that we're doing to help patients of our partner hospitals. And again, thank you very much. I thought I'd keep that very brief because I know time is an issue.
Thank you, Norma. You've got a lot of different touch points that I look forward to hearing about when we get into this discussion. So on that note, let's move into more of a discussion here. The idea is that we were going to pose some questions to the panelists and hopefully generate some good back and forth discussion. We will try and weave in some of the questions that if you posed a question during the registration process, or if you do so during this session right now, we will try and weave those in as much as we can. If not, we may save them towards the end, and any that we can't get to, we will follow up with after the town hall. But I wanted to pose the first few questions to Stuti and to Carrie on the Medicaid redetermination process, recognizing that this is such a current and such a ongoing process. But to ask generally, what's your sense of what is happening now, and what kind of change does it represent, I guess, since the beginning of the pandemic?
Sure. So we've got a lot of folks on this call, and I realize people may have different levels of engagement with Medicaid policy. So I'm going to do a little bit of background work, and my apologies, or background explanation, and my apologies to folks who've been following this closely. But essentially, as we're generally familiar with, in January of 2020, the U.S. Department of Health and Human Services declared a public health emergency for the U.S. due to COVID. There was also some federal legislation about COVID. And as a result of all of those things happening, the federal government offered enhanced Medicaid reimbursement to folks, to states who suspended redeterminations of Medicaid eligibility during the public health emergency. So generally speaking, so every state Medicaid program is a little bit different, but the general rules of Medicaid are that you do need to regularly renew your eligibility. Almost all, public benefits that are means tested, that you have to be poor to receive. There's some kind of redetermination period. For Medicaid, it's generally 12 months. But during the pandemic, that requirement, which is a federal requirement, those redeterminations, was suspended. And so essentially people who became eligible for Medicaid stayed on Medicaid unless they moved out of the state they were in, they died, or they asked to be removed from Medicaid. And what we are seeing now is the end of that suspension of redetermination. So you'll oftentimes hear it referred to as the continuous coverage period. And so the continuous coverage period for Medicaid ended March 31st of this year. And that means that states could start terminating people from the Medicaid program for ineligibility starting on April 1st of 2023. And likewise that the restart of redeterminations, which are sometimes called eligibility reviews or sometimes called renewals. I tend to call them Medicaid redeterminations. That's the term we use most commonly in Illinois. The federal government told states that it was time to start that process again, and that over the next 12 to 14 months, all of our Medicaid members in all of our states need to have their eligibility reviewed. This is a big undertaking. To even go back to what was the norm. And it's a big undertaking for a couple of reasons. One is that we have a much larger enrollment in Medicaid than we have had historically. So I'm always using the KFF data, and Studi, you can put some links in the chat. But according to KFF, between February 2020 and March of 2023, Medicaid enrollment grew by 20 million people nationwide. So it grew by 20 million people. It grew in Illinois, for example, by about 1 million people. That was fantastic. It reduced the nation's overall uninsurance rate, and it gave people access to robust coverage that covers basically all medical needs. But what it means is that we have a lot of folks on Medicaid who may no longer be eligible, right? So their income may have changed. If they're subject to an asset test, their assets may have changed, and their household membership may have changed. And so they may be ineligible for Medicaid. And likewise, we have a lot of folks who have an expectation of coverage through Medicaid, right? They've been able to go to healthcare providers with their Medicaid card and get coverage, who may now not have such a clear path to coverage. So they may have an option for coverage in another way, or they may now be ineligible for coverage. The other reason why this is so significant is that redeterminations did not go brilliantly smoothly pre-COVID. In Illinois, it was a perfect example. We had about 30% churn every month of our redetermined population, which meant that 30% of the individuals terminated from our Medicaid program returned to the Medicaid rolls, actually never having been ineligible within 3 months of their termination. So they were basically improperly terminated. They were still eligible for the program. So we saw rates about 38% in Illinois, and that came for reasons which are commonplace around the country. Notices not getting generated and mailed by the state Medicaid agency, the US mail not delivering mail adequately in certain areas, people getting the mail and not really understanding what to do with it, and people returning their redetermination forms to the state and the state not processing them. Also KFF has predicted a range of potential rates of improper disenrollment, meaning people are still eligible. It may be that they have not complied with getting that notice, but they remain eligible for Medicaid from, I think it's 7 to 33%. So they've picked a general average of 18%. Which would be 17 million people across the country losing Medicaid. 17 million people. In the state of Illinois, that could be as high as 700,000 people. And for you guys in direct services, right, you know what that means. That's 700,000 human beings who currently have healthcare coverage, who are going to get a notice that says that they don't have health coverage anymore. And a significant number of those folks are going to be kids. And many of those folks are going to still be eligible. And many of those folks are going to have done everything that they know to do to keep their eligibility, and they're still going to be off. So the stakes are incredibly high for Medicaid members. And the volume is incredibly large throughout the country. And so I think that means we're facing kind of a significant situation. So that's really the kind of history and backdrop, if I have answered all of those initial questions.
Yeah, I wanted to follow up, Carrie, and maybe Brad, you could chime in here, or anybody who has something to add to this. Are we able to identify what the biggest trigger is for people falling off the rolls, or is it really that there's just so many things that are happening at once that it's difficult to pinpoint? And I ask that because it sort of leads to well, then what do you do about that? Or what can folks do about that? What role can they play in helping to address, whether it is an administrative barrier or something else? But do we have a sense of that at this point?
So we definitely do. Mercifully, KFF has been tracking, and it does seem as though it looks like from their data from the states that are reporting and making it publicly available that the median disenrollment rate is about 34.5%. And in some states, the share of procedural disenrollments or administrative terminations is above 50%, so 80% in Arkansas and nearly 55% in Iowa. And I would say in Illinois, we're likely to see between 30 and 40% procedural terminations. And so I think it is going to be the largest driver. Now you have to break that down a little bit, because is it that, again, that the notices did not go out timely? So Illinois has stood up another printing office, for example, just to get out 100,000 notices every month. So we have to, in order to do this in 14 months, we have to get out 111,000 notices a month in Illinois. But the fact that they're standing this up suggests, yikes, we don't actually have the capacity to even print all these notices. Then we have backups in the mailroom. We have issues with budget for postage. And so getting the notices out may be an issue. We have a huge issue with the US Postal Service, people getting their mail. In Illinois, we're not doing anything with the envelopes to indicate their level of importance. And so people are going to be like me and have all of their snail mail on their dining room table and not answer it. And then likewise, we have a portal, a customer portal, where people can electronically complete their redeterminations. But obviously, we have a huge digital divide in this country, and Medicaid members are much less likely than other folks to have access to the tech to complete these redeterminations digitally. We also have barriers to getting access to the digital system because of the identity proofing that's required. And the state has, of course, allows people to mail their redeterminations back, but we don't really actually have the capacity to process that mail in the state of Illinois. And so in all likelihood, if you snail mail back your Medicaid redetermination, it won't be processed. So while we can say, I think procedural administrative terminations are likely to make up the largest single reason for Medicaid terminations, because in Illinois, it's not going to be ineligibility, frankly. The fix requires parsing just a little bit more and doing a little bit more of a root cause analysis. But I think that we can get the most bang for our buck looking at those administrative terminations, legal aid organizations working with their health partners to track what's happening and what the root cause issue is, and then to try to have the state make policy fixes or structural fixes or tech fixes to get around it. The other issue is that a lot of people who are going to become ineligible in most states, there may not be a policy fix that's easy and on the table. So if, for example, you got onto Medicaid because you were a pregnant woman or a pregnant person and you delivered, and now your immigration status bars you from federally funded Medicaid. If you don't live in a state that provides a Medicaid lookalike program that covers you, then you are going to be ineligible for Medicaid. And in general may have access getting any health insurance. So while I fully support every state doing state-based expansions of Medicaid, and Illinois is expanded down to age 42 for folks who aren't eligible for federally funded Medicaid, that's a great initiative. As a practical matter on the redetermination process, I think we can get the most bang for our buck tracking what's working and what's not working practically with those administrative terms.
Thanks, Carrie. Brad, anything you want to add there, or can I pose a data-related question for you?
No, I think that's a really excellent summary of the reasons people get kicked off, especially the most concerning ones. I guess the only thing I would add is, it's going to play out differently across different states. All states have taken different strategies to update their systems for these redeterminations. Some states have done massive outreach campaigns and different approaches in other states. So it will play out differently for different states. And I guess I might also add that we, if we're seeing a lot of children get disenrolled, that is a concern, because if they're disenrolled, they generally have higher income limits. So it's more likely that if they're disenrolled, they actually still qualify. And it's more the administrative reasons that Carrie was talking about to see high numbers of children disenrolled, and why that's particularly concerning.
So what can folks do to help their patients navigate this process? Specifically, I'm thinking about the role of a navigator. What does that look like, or other staff, especially at an MLP? And there's a patient who comes in who maybe received a letter, didn't know what it meant, or didn't receive a letter, whatever the trigger may have been. What are the roles that, in particular, navigators or others in these programs can play?
Yeah, so talking about legal aid organizations, I mean, again, I think a lot of the folks listening on the call are going to be like, yes, 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 Carrie. Like, of course, we're doing all those things. I think some things we're doing in Illinois are we're creating a notice bank. So like, what are all these notices looking like? Are they appropriate? Do they have the, due process language that's required? If somebody might be eligible for spend down Medicaid because they got Medicare during the pandemic, but their income is a little bit high for, ABD Medicaid or Medicaid for older adults and people with disabilities. Did they get a notice that informed them of spend down eligibility? But again, a child being terminated, are they being screened for the state's CHIP program, which has higher income limits? Does the notice tell them anything about that? So do the notices comport with legal requirements, due process requirements, et cetera? And then also, are they helpful? Are they in plain language? Are they clear? And do they tell folks who might have a path to coverage how to access that path to coverage? Also, we have a technical assistance sort of group called Help Hub. And so we have about 1,200 navigators statewide that have access to ask a question of folks like me and get it answered within 24 hours. And we use that to crowdsource information about what's happening with redeterminations in Illinois. So there may be listservs and extant coalitions in your state where you can gather information, because part of what we need to do is be responsive, right? What are the issues and what aren't the issues? What are best practices? This fax line doesn't work. This fax line does work. Here's an email where you can get somebody back on who's been improperly terminated, who can't get their psych meds, So I think we need to be nimble as we see what the problems actually are. Some folks have used, no patient identification Google Doc with the health center to be like, put all your issues, all your terminations into a Google Doc, and we can start to see trends in there. So I think trends watching is important. And then just, are there impermissible policies? CMS has issued guidance, but there's also federal regulation and federal Medicaid law, which are controlling law, making sure that your state is following the law. And then navigators are, absolutely critical to this process. So they can send folks to legal services if they think they've been improperly terminated. They can tell people what their options are if they've been properly terminated from Medicaid. They can help with the tech, right? I can get you enrolled in the customer portal so that you can get access to information. I can help you fax in your redetermination so you're not in Illinois snail mailing it and having it go essentially into a bin somewhere. I can help you make sure that the system has a correct address for you so that at least we have the best possible chance that the notice is going to arrive at your where you're currently living, because obviously there was a tremendous amount of transients and address changes for the Medicaid population during the pandemic. So really, I think both groups, legal advocates and navigators, are absolutely critical frontline folks. There is no way that state human services agencies in any state in the union are adequately staffed for what they are facing. Certainly in Illinois, a solidly blue state, we have, I think we may be between 30 and 40% of caseworkers who have never done a RED before ever, because we've had so much turnover and we've lost so many caseworkers. Illinois has a great communications toolkit. There are going to be billboards and buses, but there is no question that the trusted voice of your healthcare provider and the trusted voice of an embedded legal services person saying, this is really happening, you have to do something. Because for most folks, there will be some renewals that can be done automatically. We call those ex parte renewals. And Illinois has been doing those renewals, not terminations, but renewals during the pandemic. But for most folks, the train starts to leave the station when that notice is generated. It means that if you do not take an action, you will lose your Medicaid. So if you are not getting an ex parte redetermination, you must act or you will be terminated. And we, I think, are excellent messengers for that, and to help people understand that this is not something that, while they've been able to, for the past several years, not engage and keep their coverage. Now things have changed. They're going to have to engage. And so I think those are the groups of ways that legal services folks and healthcare folks can do the most help. And it's a great synergy, right? It's perfect for MLP. Like, what are you seeing at the health center? What are the notices that are folks bringing to you? When are folks in a health crisis and their health coverage is over? It's a great opportunity for us to work together.
Agreed. Carrie, you have a lot of really practical on the ground experience and feedback. And I think it's a really good pair with some of the data that Brad and KFF have around the numbers of people and, of course, state by state, the differences depending on where in the process each state is. Brad, I'm curious if the data that is available and that you all have collected, does it have things? Is it disaggregated? For example, do we have data on like racial or ethnic breakdown in this space, or is it going to be more of what Carrie was suggesting, where maybe you have a Google document and people are kind of sort of crowdsourcing some of the information about what's going on, or is that collected on a national level?
So as part of the unwinding, states are required to submit reports to CMS. States have been doing that. It's been at the discretion of the states to make them public so far. And in legislation, the Consolidation and Appropriations Act, basically the funding bill from December, said CMS will make this public. And we're kind of waiting on that because that will be the best standardized data that we have to date. Unfortunately, not a lot of breakouts. It's very high level, very simple, just how many renewals were successful, how many were terminated, for what reason, and things kind of like very high level like that. That said, so far, some states have started reporting renewal outcomes, but they're all doing it kind of how they want to and what's important for their state priorities. So there are some states that are breaking out by race, ethnicity. Offhand, I think like maybe Arizona and Minnesota, but I might be wrong about that. But states are kind of taking their own approach to the data reporting, and it is kind of hard to do an apples to apples because the populations might not line up, the time periods that we're reporting might not line up. Some states are only reporting about disenrollments, others are talking about renewals and disenrollments. So it can be very confusing to make sense of it. So that's why we're really waiting on this national data from CMS to come out hopefully soon to give us kind of a better national, more standardized picture across the states to see how, do the comparisons across states.
So this is Leighton. Can I say something?
Of course you can, please do.
So I'd hope that, at the ground level, what you guys can do is first try to understand what's going on. And some of the data is being reported in the sources that Bradley is talking about. But in some cases, you have contacts into the states, or through what's going on in your community health centers and the hospitals and the emergency rooms, what's happening. What I'd say is obviously some of the things that you can do are trying to be helpful in navigating and helping individual patients. But the other thing is doing the rabble-rousing bit of advocacy that advocates can do, which is they're sort of saying and trying to get articles in newspapers about why are we losing people? Why are we not having explanations, reminding states that actually there's lots of federal money to help out during this period. Federal matching dollars were provided to help ease this period. In addition to this, that states are frankly speaking sitting on billions of dollars that still are left over from the public health emergency that have not yet been canceled that could be helping to fund call centers, further administrative resources, et cetera. And there are all these things that could be done. There are things that could be done by other activities. So for example, now when I go into my drugstore, I notice the pharmacist desk, there's something that says to everybody, do you have Medicaid? Are you up for Medicaid redetermination? If not, here are ways to get information. This is so important because people need to get their drugs basically every month. So that's a low cost way that my local drugstore is trying to help in this effort. But there has to be some place that they can call and reach. And that's where efforts from you guys can help make sure that there are those places that people can talk to. And again, a critical thing is does the Medicaid agency have your address, have contact information for you? If you are not up for redetermination right now, when they come to it, do they have ways of contacting you? That's probably the biggest source of why there are these procedural problems, is frankly, states have lost contact with Medicaid recipients.
Yeah, a really good reminder of the number of different ways that folks on this call and generally advocates can, have a touch point to this and have a way to influence or to impact the people who really are relying on Medicaid. I will just put a call out to see if there's any last commentary on this discussion topic before we move on to work requirements. Okay. Hearing none, let's move on and talk about work requirements. And for this one, I'm going to turn it back to Leighton and to Brad and ask generally if you can give a brief overview. And I'm laughing a bit to myself simply because the last couple of weeks on the debt ceiling negotiations, it seemed like there would be a different answer to this each day. But sort of a brief overview of this as a policy topic. We know that there's some history several years ago on states implementing work requirements in the Medicaid waivers and some litigation on that. Where do things stand today? Sort of what is the landscape, I guess, as broadly as possible for this topic?
And Bradley, are you going first?
I'll let you go first, Leighton.
Oh, okay. Well, so at a big national level in the debt ceiling requirement, we dodged a bullet. So there are some changes in work requirements for SNAP and for TANF, but the president and his negotiating team basically said, don't change Medicaid. So at least for the time being, Medicaid work requirements are not an issue aside from one state, Georgia, which will be implementing work requirements sometime soon because of they had a waiver approved, there was litigation that went on, so they will begin in July. There are other states that are interested in applying and have applied for work requirements. It is unlikely that CMS will approve them. In addition, the court decisions before sort of frowned on work requirements. So, but they may come up. What I'd like to point out to people is though we dodged the bullet in Medicaid, we did not dodge the bullet in SNAP. So what's come up in the headlines is that SNAP work requirements were increased in the debt ceiling. To my mind, that's not the important thing. The important thing is that what's happened is under the public health emergency, work requirements were suspended in SNAP. Now that the public health emergency has ended, they are coming back in SNAP. So consequently, sometime around now, in the majority of states, work requirements are coming back in SNAP. And we have done research in this before. I will say, me and my colleagues have done research. We looked at SNAP work requirements across the country over many years. It's very rapid, it's consistent. When SNAP work requirements are re-invoked, and so states can get waivers, but they are harder to get, particularly now that unemployment rates are down. When SNAP requirements are reimposed and there is no waiver from the state to suspend them, about a third of the able-bodied people, adults without dependents, the ABODs, lose coverage within about 3 months. So you see very rapid disenrollment. The sad truth of the matter is that there is very little that states do to help people get employment. The activities are tough, and essentially speaking, It's a way of thinning the caseload very quickly. So this happens rapidly. I will say in research that we did, what we found is this: there is a racial component to this. Black people lose benefits at about 3 times the rate of white people, though this is termed as something that is affecting able-bodied people. We find that disabled people lose benefits as well. So there's a lot of administrative chaos. What will happen? We'll be watching Georgia closely for what happens in Medicaid. But the truth be known, we've known what's going on in SNAP because SNAP has been doing this for years and years and years. And the pattern is quite consistent. People lose benefits. Very few, if any of them, get employment help. Certainly is not long-term help in terms of their employment or their income. So there's this theme that comes up before, and I get the ideological component that says that we would like to have people on welfare work and that this is a way of helping them. It is not a way of helping them. All the efforts to sort of help unemployment are very minimal. There may be some additional components under the legislation that might help, but the truth be known, there's not much reason to feel optimistic about it. As Brad mentioned, most of the people on SNAP, most of the people on Medicaid are working already. So the people who are not working, and typically are people who have major reasons why they are not working, whether it's their own lack of skills, lack of employment opportunities in the area, transportation, childcare problems, etc. So work requirements are problematic, but will be a much more serious problem in SNAP soon. And we all know that SNAP is the day-to-day component that provides day-to-day sustenance for helping families. So though it's not directly affecting Medicaid, you are definitely undermining the capability of SNAP recipients who are very similar to Medicaid participants by and large to sustain food for their families. And so with that, I'll pass it on to Brad.
Oh, I think that's an excellent summary. And yeah, I agree. We dodged a bullet. I think for, Medicaid at least, yeah, the Biden administration has shown by when, when first getting into office, withdrawing approved work requirements and the most recent debt ceiling negotiations, holding the line on Medicaid requirements. I think at least for Medicaid, while the Biden administration is in office, they've drawn a pretty clear line for Medicaid. But yeah, I mean, for the program, it has dodged a bullet.
What are there a sort of, and I recognize that at this point, we know that we dodged this bullet last week with the debt ceiling, but I'm curious sort of what, you talk about Georgia, Arkansas is going back to the drawing board. What sort of lessons can be learned, or what sort of data, what do we know about work requirements and how effective they are, or whether they are effective? And I recognize that answer may differ a little bit with SNAP versus Medicaid, but are there any themes that, in particular, those who are in a state where either have a lot of folks who are receiving SNAP and now have to deal with this, or maybe they're in Georgia or potentially another state, just an awareness of what we learned the last time or the most recent time? What sort of lessons can we bring forward?
So the lessons in Medicaid are small because the only work requirements that ever imposed came in the state of Arkansas for a few months. The information that came out showed that lots of people lost coverage, that almost nobody gained employment, so that it was mostly creating harm, not help. Where we do have more information historically is out of SNAP or out of TANF. Again, the research is very consistent that people lose benefits in very large numbers. Many don't, because many people are working already, but nonetheless, very large numbers do. And that, I will say, the information on the extent to which people work more, that is this a suitable work incentive, is a little mixed, but generally the evidence is it's very thin. And ultimately, the reason is because poor people get that work is the way that you put, food on the table, generally speaking. It is not as though poor people are sitting around saying, my God, I'm just so happy to live on the dole and I don't need any of these things, so I'm going to be a lazy bum. That's the mindset that is in the minds of conservatives. That is not the reality on the street. Actually, I recently had a high school student who was doing a project in the state of Delaware where she surveyed a number of SNAP recipients, and basically what she found, all of them recognized that work is important. They wanted to work, and if they had the opportunity, they were going to work, even if they had to lose Medicaid benefits. They get that. The problem is again, it's an ideological argument. It's an ideological argument that can be used to batter poor people, basically to make the image that they are lazy, and that if they are lazy, they should be pushed off their benefits. I will say the framing is typically, and I understand why this is powerful framing, should people need to work in order to get public assistance? The great majority of the public would say yes when you ask that question. On the other hand, if you reframe this into the context of should people lose benefits if they can't get a job, then in that case, the decision shifts around. People say, no, people shouldn't lose benefits if they can't get a job. So you need to, be aware of the rhetorical arguments. This will come back in federal legislation again, though the Biden administration held off in the debt ceiling votes. Do I know that they'll be able to hold this off forever and ever? I'd hope so, but we also know that this administration will be in for 2 years, and who knows what the next administration is. So this is an issue that will come back. It is an important ideological issue for a number of conservatives.
And I guess kind of to build on that, if and when these do come back, there is going to be, the administrative record is going to have to show how they address these coverage losses that we see, because we know from the experience in Arkansas, that it did result in coverage loss, and including among people who were, meeting, otherwise working or qualified for exemption, but just fell through the cracks because of reporting snafus. So we know that there's a negative impact. The courts also found that that's a major reason a lot of these waivers were, paused pre-pandemic. So, I mean, that's one big takeaway. We also know that the people who lose the coverage experience a lot of hardship, paying medical bills, cost-related delays in care, accessing medications, things like that. And to Leighton's earlier point, we don't see a whole lot of improved employment numbers from these, at least from the research so far. And then I guess I would also just add, these are just administratively complicated and can be expensive for states to implement, often of which is, partially matched by funding from the federal government. So they're complicated. They can add to the administrative expenses. And I guess at the end of the day, there are better ways to support Medicaid enrollees and to Medicaid enrollees find work among the ones who aren't working or have barriers to work. So like I mentioned earlier, this can involve things like referral programs or case managements or job screening and referral. But when they're voluntary, when they're targeted, we've seen that there has been improvements, at least in increased income and things like that from some other state programs like in Montana.
Great. Bethany, you have a tip for MLP?
Yes, because in fact, just for the audience members, Leighton Koo, Brad Carallo, some of the folks who were former MLP practitioners and are from the legal aid community in Arkansas who went through this, many of us who worked on this a few years ago, really recognize the power of medical legal partnership, even if you did not have a formalized MLP. So I really want to use just a moment of this audience's time to encourage you from the healthcare side, if you are not currently connected with a civil legal services provider, even a law school, with a clinic in your community, to do so right away. As we increasingly see these proposals to attach work requirements to Medicaid at the same time while we're dealing with redeterminations, and trying to gain coverage for additional patient populations. It's really going to be important to connect in some way with your civil legal services providers in the community, whether it's for the purpose of trying to stave off loss in coverage by helping people receive education and complete those applications the right way first time around, or even educating some of the folks on the agency side. In Arkansas, it became extremely important to be able to identify the beneficiaries who are being affected. And that came about because of some really great relationships that the legal aid providers in Arkansas had with various types of healthcare providers, PCA, hospital association folks in the state. If you can't find these beneficiaries, it makes advocacy virtually impossible. So please, I encourage you all, as these various policies continue to be proposed that could cause beneficiaries to lose coverage when we're already dealing with redeterminations, start to connect with your civil legal services providers. I'm not even asking you to start an MLP, I'm just asking you to identify your legal services providers in the community, and then we'll continue to go from there. Thanks, Katie.
No,
And
thank you for
those of
jumping
who are
in.
Georgia, we'd love to hear what goes on in Georgia starting soon.
Mm-hmm. Indeed.
Yeah, it goes to this question that I had, and maybe it's sort of obvious based on that comment, Bethany, which is, what can healthcare providers do to help prepare their patients for something like this without, unnecessarily causing despair and fear and anxiety, but sort of the being prepared. And I think that looks different whether you are an MLP or you're a legal services provider or a health center, and finding out who your potential partners are. And maybe there isn't a good answer. I don't know. Maybe there isn't a good answer for how to prepare your patients. If you are in a state that wants to do this, Kentucky, Arkansas, Georgia, where it's going to happen, there may or may not be an obvious role without causing, just a lot of anxiety amongst patients. But I welcome any comments or thoughts on that before we move on. Any other comments or points for this discussion topic before we move on?
I would just say, just really quickly, I'm sorry, because I find this just so incredibly frustrating, that I think it's really important to understand the structure at work here, right? You defund your human services programs consistently, then you create elaborate administrative processes that they do not have the staffing, the money, or the tech to deal with. And it is unequivocally a way to disenroll people from programs. It is a strategic, intentional plan to disenroll people from programs. We're going to put administrative burdens that neither you as the recipient nor our state agency can handle, so that you will be terminated. And our Medicaid rolls, for example, or our SNAP rolls will go down. And I think it's important for us not to lose track of the fact that it is an intentional plan, because you can't fight an intentional plan with good faith efforts to comply with it. Sorry.
Don't apologize. You're absolutely spot on. These are, as somebody said earlier today, or maybe it was yourself, Carrie, these are X number of human beings that are being impacted. It's not just policy as a big amorphous, faceless, nameless thing. They are actual human beings. So very, very good reminder. Let's move on to our final topic, which is Medicaid coverage for undocumented persons. And primarily here, I'll focus the questions, direct them to Jay and to Norma. And I'm wondering if one or both of you can just give us a little bit of a primer, an overview of what the rules are if you are an immigrant for receiving Medicaid.
Thanks, Katie. In the interest of time, because I know we're getting a little bit kind of toward the end, Brad, I don't know if you want to take credit for another KFF publication, but health coverage and care of immigrants is the best place that you can learn about the kind of ABCs of coverage for immigrants, specifically on page 8. I'll drop it in the chat if I get a moment, or maybe Bethany, you can find it. But Basically, without spending too much time, because we could have an entire webinar on the intricacies of eligibility for immigrants and PRU-call and the old kind of terminology. But, there's basically folks who are here with legal status who may qualify for coverage under Medicaid, but most cannot receive that for 5 years. There is a 5-year ban, although some states may and have permitted through federal permission pregnant persons and children to be enrolled in Medicaid as a result of some fairly recent additions to that. And again, the general rule for people without legal status, people who are quote unquote undocumented, are not eligible across the board. But I think in part 2 of this, we'll focus on those states and specifically those endeavors and those initiatives that have created an opportunity for that cohort of individuals. So I'm going to refer the specifics and the nuances at least to that KFF bulletin, and I will focus a little more on Connecticut and other state opportunities in a couple minutes.
Great. Can I ask, you mentioned PRU-call. Can you explain what that is, what role it has in enabling some immigrants to access healthcare?
I'm going to let Norma handle that one.
Great. Norma, you're on mute.
Sorry about that again. So PRU-call basically refers to people who are permanently residing under color of law in the United States. It's a public benefits eligibility category and includes benefits like safety net and Medicaid, which we're talking about. It's not a federal immigration status, and it's not really recognized by the Federal Immigration Agency. PRU-call is generally very limited nationally. It's not available in most states. Only about 6 states allow individuals access to Medicaid benefits. New York being among one of the more generous ones. There's California, Connecticut, Hawaii, Illinois, and Massachusetts. In many states that do provide PRU-call, benefits can be more limited than they are in others. So it's really a hodgepodge of rules that's different from state to state when it comes to PRU-call benefits. And in most states, there really is no PRU-call access to benefits for immigrants and undocumented people who are not qualified aliens under the federal rules, meaning they're not green card holders or asylees or have other humanitarian statuses that the federal government recognizes for Medicaid benefits.
Yeah, I mean, part of the difficulty is really knowing the landscape of eligibility for qualified individuals who are here residing with legal status. And then even the subcategories of folks who are refugees and asylees who are automatically qualified from day one, and people who may be under an adjustment of status. So it's a kind of a subcategory and expertise area that requires a lot of kind of digging down in some of this. But the idea is that there are significant restrictions, even for folks who are here and admitted with legal status under a quote unquote green card who are qualified, because of the restrictions that the federal government has instituted on paying for this, and for obviously reasons of, for whatever, again, without getting into too many details of the prior logic, waiting 5 years. And that's why many states have taken the initiative to fund these programs themselves.
It sounds like, would it be fair to characterize this as there are certain pathways available if you live in certain states, or a likelihood of certain pathways to coverage being available in some states? And I think, Jay, at the outset, you made a remark, in some states you can go out, you can take a lunch break, that it really is very highly dependent on where an individual resides and what the specific programs are in that state.
I think that's fair. And even within those states, there's a significant variability of the scope and extent of coverage under state-funded programs. So some states are pretty significantly identical to the quote-unquote regular Medicaid program, and others just offer preventative care, for example, like Massachusetts, and a menu of options which are not significantly representative of full-scale coverage. And again, we're talking then even narrowing down the coverage for individuals who are here without legal status, children and young adults, to basically eight or nine states in the District of Columbia. So Washington State, Oregon, Illinois, Massachusetts, New York, the District of Columbia, Connecticut now, California, of course. And I may have missed one. If I did, I apologize, with Colorado and New Jersey on the horizon. And then within those states, there's significant variability. And one of your pre-questions on the was, do we have like a national movement in blue states? And I wouldn't really call it a movement. I would call it a very slow creeping something, which is really variable and dependent on states' willingness to use their fisc to fund these programs. Even though Connecticut has a humongous surplus now, I'll tell you in a moment or two why we can't even get full coverage for children and youth, although it's significantly better than other states. And states can't use some of the largesse of the rescue plan money and all the other federal monies that poured in to pay for this coverage. And they know a lot more about how they can do this than I, but it's been pretty well documented to us that you can't do end runs around that money and then earmark it into general funds and then put it back into the Medicaid program. It's pretty significantly audited. So it's really dependent on the state's willingness and the impetus to provide coverage, which may depend on the number of individuals who are there who might qualify, given immigration patterns and resettlement of undocumented young individuals and adults, et cetera.
That's a good segue. I was wondering, Jay, if you could speak to the work that you've done in Connecticut, because it does, like you said, it's very much the willingness of the actors in that state, and what Connecticut has achieved may not be possible in another state, and vice versa.
Yeah, I mean, I'll be really quick here. So, about 5-6 years ago, we started working with providers, medical providers who had reached a significant level of frustration in not being able to provide really just basic baseline coverage to children and youth. And we worked very hard and really got nowhere, even with legislative champions who were sympathetic. But the onset of the pandemic, and I think a kind of mindset shift of the real basic needs of communities that were so underserved and had already experienced significant trauma did change the dynamic a bit. So as of 2022, Connecticut passed legislation to provide coverage, full Medicaid coverage and CHIP coverage to undocumented children and youth up through the age of 12. Why they picked 12? Because it was more than 8 and less than 19. Like, it's just the kind of way it was. And there was no logical reason. And they, again, there were some really wonderful arguments in the legislature that our allies got up and said things like, well, are we going to legislate against children from getting sick who are now 13? Because obviously we need to do that if coverage is only through the age of 12. So there were some pretty powerful statements. The bottom line is kids are fully covered now who are here with, as long as they're qualified by virtue of income eligibility, regardless of their immigration status as of January 1. And figures I just got today indicated that there are over 5,300 children who are now insured in the state of Connecticut, 5,355 as of the end of May, which is pretty good for 5 months, much higher uptake. And then in the second band, about 100 kids. And then the legislature has just passed today and yesterday a increase in that age limit up to through the age of 15 up to 16. with grandfathering in up through the age of 19 of those individuals. But again, a lot of it's dependent on the availability of money in the budget. So it's within available appropriation, which we were trying to get out. So we've made some progress, and this was because of those 4 categorical partners, the funders, the stakeholders from the grassroots organizations who really stepped up, the advocates and the medical providers. That's where we stand now, but it really has been an extraordinarily vibrant partnership of a lot of different folks and some obviously critically key legislative leaders who have taken this to heart.
Aren't you just sort of helping to close us out on a high note here? Congratulations on that work. I don't want to cut off conversation, but I do want, and I saw a question come in that is on this topic. Norma, if you could share a bit about what Legal Health has been doing to help immigrants and those who are undocumented have access to different types of healthcare.
So a big focus of our immigration work involves making patients PRUCAL so that they have access to the broad range of medical benefits that the state has available to them, including safety net assistance. More recently, our supervising attorney Brendan Davis helped to expand access to safety net assistance as well. When we interview patients at our individual clinics, we seek ways to achieve immigration status as well as healthcare. So it's a 2-part interview where we try to do both, and when we can't, we try our best to achieve healthcare and better outcomes for our patients. So we file the whole gamut of applications, including anything that would qualify someone as a qualified alien or make them lawfully present under the temporary benefit statuses in immigration law to make them eligible for benefits. We look to history to determine whether persons have maybe filed something in the past. So we do our best to try to make them fit under the definition, which is pretty broad and generous in New York, to show that there's knowledge and acquiescence and presence in the United States to help them achieve coverage. And when we can't find anything to achieve PRUCAL status for someone in their records or history, or we can't file anything, we do file something called medical deferred action. And we've been working with transplant teams at our various hospitals to help them achieve transplants. We not only help with liver transplants, but we do a whole host of organ transplants, heart, lungs, kidneys, stem cell transplants, drug trials in order to achieve better outcomes for the patients that are being sent to our clinics. Basically, that's most of the work that we've been doing on the medical deferred action piece. And it takes a lot of time doing the history and background checks for people, doing a narrative, explaining their medical conditions, explaining the equities that are in favor of a condition. So with medical deferred action, we're basically just asking the federal government to defer negative action or enforcement against that person because they have a serious health condition. And we're basically saying, hey, I'm here. Although I'm unlawful, please don't deport me because I have a serious medical condition and that requires that I remain in the United States for continued care. And these applications are very difficult because we have to find equities. We have to do our best to protect the client from enforcement action should they possibly have adverse histories. And to do the work, it requires a lot of collaboration with the transplant team, with the person that is ill, who is our client, and the patient of the hospital. And the work we do sometimes can take a time. It takes a lot of review of all these histories. some of our work was reviewed in an article that was is sent in the chat room. People can take a look at that and get a better idea of the difficulties of achieving these transplants. But we've been very successful in having a lot of our clients achieve transplants. And you know, more recently, we achieved transplant for someone by helping them file an application for a U visa. And for the first time after maybe 10 years in dialysis, that person was able to get a transplant, although they do not have the legal status that would be required in other states. But because of the New York's broad and a generous definition of PRUCAL, that person was able to achieve the medical care that they needed.
That's amazing, Norma. It's amazing to think about the strength of all of those partnerships and all of the different professionals who are collaborating and the expertise that is required to navigate such a complicated set of rules and medical and legal to have that outcome for a very, you know, life or death, very critical and time sensitive medical condition. I'm blown away by that and really grateful for you all and your colleagues for achieving that. I'm going to just ask Bethany, I noticed that there is a lot of activity in the chat, but if there's anything that you want to flag, this would be a good time.
Yep, we're going to close out smoothly. We are not rushing the closeout on this very important conversation because I just want to note again that and I can't remember which one of our panelists mentioned it, but any one of these topics could have had an entire session or webinar or issue brief dedicated to it. And there are a lot of moving parts right now when it comes to Medicaid policy. We didn't even begin to discuss you know, the variations for MLPs working with different types of civil legal services providers who can help on these different types of issues and how you can engage in the policy work versus the direct representation or education work that occurs, not just with lawyers, but with the non-lawyers that engage directly with the community and are very, very much trusted by the beneficiaries and community members that are served. And then there are also, of course, the researchers who are continuing to gather data, and we know there are variations in data. So we could have dedicated an entire webinar and discussion on what are some best practices in terms of data collection, since there's so much disparity when you look at it at the national level. In the chat, there was conversation and a lot of sharing going on. And so I just want to note that just as a reminder, we will be sharing the recording of this conversation, as well as you saw that we purposely didn't do content slides, but we'll share the slide deck as an archive on the Medical Legal Partnership or NCMLP's website. It won't be in Box. I think there's an access problem with Box, but there's also resources that were shared in the chat, and in a follow-up email, we'll be sure to share these resources to KFF, to the articles, as well as the published article that the legal health team recently put out earlier this year to talk about their program and how they're able to help undocumented immigrants continue to gain access to transplants. More to come on this. We really encourage you all, if you're on the healthcare side, conduct the social needs screenings, connect with the legal services providers in your community. Definitely feel free to continue to look at what data is being collected at the national level, but don't forget you have data that you're already collecting and everything from the screening tools to your EHR, and can work with university partners in the community to help you analyze that data if you don't have that capacity available on your team. Katie, I'm going to pass it back to you to see if you want to gather one snippet, like a 5-second takeaway from each person here today, because again, I want to make sure these experts are respected for their expertise and are able to share in 5 seconds a key takeaway to continue to motivate us. Congrats to Connecticut on the policy achievement.
Yeah. Can anybody limit it to 5 seconds? No, really. Parting thoughts if you have any. but before you do, Bethany and mine, Amelise and the whole team's eternal thanks for sharing all of your expertise and your experience with all of us today. So I will turn the
Can
floor.
I mention one thing? I mentioned it very briefly in the chat. It's a little gimmick that can help in even some conservative states as far as immigrants getting coverage, and it's hospital presumptive eligibility, which even conservative states like Texas have hospital presumptive eligibility. So in this situation, people can get coverage for a limited time period at certain hospitals before they go through the full Medicaid determination. This means that someone who has immigration status that might otherwise keep them from getting on Medicaid could get at least 60 days Medicaid coverage at the hospital. Hospitals like this too, because this guarantees them some Medicaid revenue. So it's a gimmick because they're not supposed to get on, but they can get on without going through the full eligibility determination that would show that they're undocumented or have improper immigration status. So this applies in lots of states. So state advocates can try to get this option implemented in their state or for their hospital.
Thanks, Layton. I love practical tips.
And I would just say really quick on Reedies, like it is exactly the DFD that we are all saying it is a huge thing, but it is the perfect opportunity for health centers and lawyers to work together to mitigate the harm that's going to happen both on individual folks and on the policy level. And so it is our finest moment. The challenge that it presents is also an opportunity to be our finest hour. And I encourage everybody to rise to it because we can do it.
Nicely said. Okay, if there are no other comments, we will close by thanking you again for this amazing conversation. For all of you who participated in the chat or just listened in, look for a follow-up from us with information, some of these resources, or when it is posted on the website, we will share that information.
Thanks so much, everyone. We're close out. Thank you to our
Okay.
panelists. Have a good day, everyone.